Well, hello everyone. This is the very first course of this particular series. This is the first lecture. And my name is Roseann Mulligan, and I'm the Associate Dean for Community Health Programs and Hospital Affairs here at USC, and also this particular course director and the director of the Master's Degree Program in Geriatric Dentistry. So our first topic today is going to be about the epidemiology of oral diseases in older adults. There are a lot of things that we could talk about when we talk about common oral health problems in older adults. We've had to just select a few for this particular lecture because a number of them will be covered in detail in further lectures in this series. So those in the right-hand column we'll talk more extensively about later on. For today, we're going to cover some basic elements of common oral health problems, and each of these five topics will be discussed individually, and we'll take a look at the literature that focuses on each of the topics, if there is literature. So the first one that we all think about when we think about diseases of the oral cavity is, of course, caries. So here's a picture of an older mouth with caries in various states of advancement and arrest. And that's fairly typical in an older patient. You don't get just one area or one type or one aspect of progression at a time, but you're dealing with multiple conditions. So the first studies that we really started looking at elderly individuals began covering the period from 1981 up to 1983. An intensive effort was made to attempt to map oral diseases in older adults, and people were looked at who were 65 years of age and older. There were actually 4 sites in the United States that were covered, and I've listed them there. And as you notice, 2 of them were on the East Coast, and 1 in the South, and then 1 in the Midwest, and there was really nothing in the western part of the United States at all. So some of this data then has been recapped recently in a paper by Walls and Merman that I will quote from that was published in 2012, because I think it's a nice example of a review paper that takes a look at what caries prevalence is like in the elderly, because there are some real problems with trying to get at this data that we'll discuss. So for example, one of the aspects that they note in their review paper is that, contrary to what you might have thought, but lesions in the crown of the tooth are more common than lesions in the root of the tooth, and that those coronal lesions are typically associated with restorations, previous restorations. So you will see in some of the literature the definition of CARS, or caries associated restorative surfaces, as a shorthand term for this condition of caries occurring where there's already been a previous restoration. So if you look at the picture and to see the arrows, this is pretty classic of where caries associated with a previous restoration occurs. Usually it's at the gingival margin of the restoration. You'll also see where there has been some overhanging margins relative to poorly finished restorations, or where there might be a gap. That's a prime spot for caries to take place. Now, the paper by Walls and Merman actually quotes a number there from Great Britain, and but they actually quote some of the papers from the United States. And this is a study that was the one that was done that looked at caries in some of those earlier studies that I noted. Remember, I said one in the Midwest, that was the Iowa study. The North Carolina study was actually, locally they called it the Piedmont Study. And if you take a look at that data, you'll see that in the crown in both of those particular geographies were higher than the root caries. And the difference in the two citations here for Piedmont, one is the white population and one is the African American, or in this case they've abbreviated it as C, the colored population. Again, you can see that the coronal caries is at much higher rates, whether you're looking at one study or another, in one race or another, than the other, than the roots. So let's move on. There we go. So there was another study that was funded by National Institutes of Health, and this was led by Chet Douglas at Harvard and his colleagues throughout the New England states, which is, you can see from this picture here, where they're located way up in the northeast part of the U.S. It was an attempt to get an even older population. No one was enrolled in the study who was less than 70, and there were many more older people in their 80s and 90s in the study than in the previous studies that were done. And in this case, these examinations were done in the home of the individual by calibrated dentists, and it was a full mouth exam. And I think that's important to have that kind of detail as we think about these studies. In this study of these New England elders, the prevalence of untreated coronal decay was 28% in female elders and 34% in male, but more than 90% of these individuals had coronal fillings and 22% had exhibited root caries. So again, just lending more credence to the fact that coronal caries outweighs root caries in our older population. I'm not typically going to talk about prevention throughout this talk, but I did want to mention, in this case, whether or not fluoride is helpful, fluoride in restorative material, since we're speaking to the fact that these caries seem to be most commonly along the margins of previous fillings, and what the findings are. And really, there's been little evidence to support the value of putting fluoride into restorative material as being detrimental to future caries when you look at the population as a whole. Some time ago, when we were using silicate cements, even that evidence was only anecdotal and not very well scientifically proven. What about the glass ionomer cements that you and I are using today? Yes, we know that they serve as fluoride reservoirs and that they can release fluoride over a period of time, but we also know that that period of time ceases and the amount is relatively small. And so when you look at, does it really inhibit caries, there has not been a proven demonstrable effect in caries inhibition. And it all sounds theoretically great, but why hasn't there been a reduction seen? And it's likely the fluoride content and release is not strong enough, it's not concentrated enough. It also could be that the study groups are just too small to detect caries because you will need fairly large cell sizes in order to have the power that's required to get a statistically significant difference. Most of the studies that have been done in the past about these materials are looking at things like retention and how well they withstand abrasion and marginal fit and color. They're not really looking at whether or not there's a caries reduction rate. And then many of the studies don't last long enough. And that's an additional issue because caries, as you know, takes a little while to evolve. However, when studies have been done and that are randomized clinical trials, and we know, of course, that that's a very high level of scientific proof if something is statistically significant using that kind of a model of research study. When they looked at the glass ionomer cements and compared them with composites, and these are in a high risk, high caries population, what is seen there, and in this case, a radiation-induced xerostomic population was used, and they still found caries developing around all restorations, whether it was the arm that was the glass ionomer cement or it was the arm with the composite. However, those teeth that were restored with either kind of GI cement, whether it was self-cure or light activated, it did seem to be better than it was with the composite. So maybe in a high-risk population there's a limited protective effect, but in the general population that has yet to be proven. And just to give you a quick glimpse of what about all of these, what's the best product to recommend to our older patient population. All of these products that we have that relate to 5,000 parts per million of fluoride, or whether it be fluoride varnish, or even the chlorhexidine, or the sodium fluoride varnish, or the silver diamine fluoride given in the proper application duration, all of them seem to be effective with very little difference. And so choosing what is appropriate for a patient may well be, the frequency of the approach may well have to do with the patient and their ability to come into the office, their ability to tolerate, or each of these different treatments that would lead to the choice that one would make. So let's go on now. That was just a brief glimpse at caries and what the literature is, and take a look at periodontal disease. Now, I purposely put a picture of an older adult's hand up in the corner to remind us that we often think that oral hygiene is the cornerstone to periodontal disease. And if we believe that, and if the science shows us that that's the case, then we have to think about how well the elder can actually perform the task of keeping their mouths clean. And that can come from the ability to do it themselves or have someone else do it for them, as well as to understand the importance and to be willing and able to cooperate with that kind of care, and to be adherent to various daily regimens. So all of these things factor into periodontal disease, and the question is, do we have literature that supports these various approaches of home care and as well as professional care? Well, let's see what kind of epidemiologic literature there is. The NHANES takes place on a regular basis, and sometimes, frequently, it is questionnaire based, but there's certain parts of it that are clinical exam based. Frequently, though, the NHANES data does not, when it says, for example, they look at seniors equal to or greater than 65 years of age, because of the settings where they do these exams, the oldest of the old, people in their 80s and 90s, for example, or beyond, are never typically looked at. So when you look at this data, you have to keep in mind that these are frequently numbers from the young elderly, or people, let's say, 65 to 75. When this was done, they found a prevalence of periodontal disease of 17% and severe periodontal disease in this age group at nearly 11%. So again, these are probably young elderly. The risk factors were being older. So the higher the number of years, the greater the potential risk. Being Black or Hispanic, being a smoker, a current smoker, and having less education and lower socioeconomic or lower income group. Now, there's another nice review of prevalence rates of periodontal disease in older patients, and I refer you to that one for a more detailed look that was done by Boehm and Scanopico. And this is just a part of the charts that were in that review. And you can see it's around the country. Yes, it includes some U.S. Studies, but it also includes people from other parts of the country, of the world. And you take a look at the prevalence rates of periodontal disease, and it depends on what you're measuring, but still you see it's significant. In this Denmark study, this is a young elderly group, 93%, for example, bleeding on probing. And you can see that pocket depths, 62% of pocket depths, 4 to 5 millimeters. And here in the Iowa study, 91% had at least one 4 millimeter or greater attachment loss, and so on. And we could go through each of these. I want you to bring your attention to the study in Germany, where they sectioned off 2 different age groups, and one of which may not even be considered old by many, and looked at them individually. And so it's hard to draw some cross correlations because many of the patients are different ages and different things were measured. But I think it's clear just from this snapshot, there's a lot of periodontal disease in the elderly. And depending upon if they're community dwelling elderly or if they're in nursing homes, that adds another aspect to the issue of periodontal disease. So let's take a look at some specific data. This happens to be a study on periodontal disease in the elders in Sweden, where they used about 1,000 people that were randomly selected, and with an age range of 60 to 96 who were already enrolled in a national aging study, and they all got a comprehensive oral exam. And some of their findings in this study were that women had these are the women who were dentate, had about 18 and a half teeth, and men had nearly 19 teeth. And look at the difference between those who had the young elderly, 60 to 66, with greater than 20 teeth. Those who had that, it was more likely 73% of them had at least one or more annual visits. And if they had less than one annual visit, it was a much smaller percentage of people who had greater than 20 teeth. And among the oldest old, and so now we're talking about people probably in their 80s, you can see the percentages are much less, to only 37% of them who had one or more annual visits had at least 20 teeth. So I think it's helpful to see some of these studies that don't just consider the elderly as one homogeneous group, because clearly they're not. As people get older and older, things change epidemiologically. We have results that clearly show that the risk for these conditions gets greater as well. So their final outcome of this Swedish cohort of elders is that if you were a dental visitor, that is, you had a visit to a dental practice, you did then have more teeth than if you were an infrequent visitor, and that was statistically significant and a significant p-value. And that's true when it's adjusted for age and the number of teeth. And that when they looked at other factors, such as how dental visits and the frequency of dental visits had impact on alveolar bone loss, the number of periapical lesions, and the number of endodontically treated teeth, all those p-values are non-significant. So it's not always that we choose to measure the right thing as scientists to be able to demonstrate what our hypothesis is. And so this is a particular example where presence or absence of teeth did demonstrate a relationship to frequency of visit, but some of these other factors, in fact all three of them that are mentioned here, did not. Let's go back to that New England elders study and look at what they found about periodontal disease. Remember, this is the one that's over the 70 years of age, and they had full mouth exams in their homes. So 66% of the dentate elders exhibited moderate periodontal pockets of 4 to 6 millimeters, and so 21% exhibited severe periodontal pocketing, and we're translating that to be greater than 6 millimeters. So I think in summary, as we move on, periodontal disease is significant in our older population, and it gets more significant as you get even upwards in years within the elderly group. We talked some about relationship of teeth to different findings. Let's look at tooth loss in particular. And we're going to look at it in the New England study that we've already referred to a couple of times. In that study, nearly 38% of elders were edentulous, and that was the dentate elders. Their mean number of teeth ranged from a high of 21 to about 18, whether it was either gender or any age in that particular study. When we look at a similar study that took place in Denmark, here you see that they didn't just attempt to gather this data, but they attempted to develop or look for a relationship as to whether tooth loss was an indicator of disability and mortality. And here they had a community-based population in Copenhagen. They were all non-disabled, and they were all 70 years old, so no other age group. So they looked at the time. In 1984, they enrolled people born in 1914, so 573 people. And then they followed them up. And that's, of course, a stronger study when we can look at longitudinal data of the exact same people over these 20 years at 5-year intervals. And you can see the N keeps going down as people are lost to follow-up frequently in this age group. It's due to death, but it could be due to other things like moving, for example, to a different location. So that by the time 20 years came around, they only had 78 of the original 573 individuals who were still around to have follow-up information gleaned on them. So they measured their oral health according to the number of teeth present. So they had four groups, those that were edentulous, those that had between 1 and 9 teeth, those that had 10 to 19 teeth, and those that had 20 or more teeth. And they also looked at a disability scale that they used and took that again at each of the 5-year intervals. And then they had a mortality data, that is the death register from their country. So these were the ways that they, the data that they collected and then attempted to draw a correlation to. And this is what their results look like. Now, when you look at odds ratio, there's the crude, and then there's the adjusted. Now, the crude data is that data that is a result of the mathematics and the statistical analysis without being adjusted for any covariables that might have impacted. So it's really much more appropriate that we look at adjusted data rather than crude data. So that's what I want to bring to your attention. And if you notice these blue markings here, those blue markings are indicated as those superscripts down here as the p-value being 0.05. So again, we just want to look at 5 years, were there any values that had been adjusted for education, comorbidity, tiredness, and physical activity? Could we draw any correlation to those things relative to the mortality register or the disability impact, and draw a correlation to the number of teeth? And at 5 years, no. The answer is no. Even though we've got some odds ratio values here that look interesting, they're not statistically significant. So let's go on to the 10-year column and look at that. And in the crude, we're going to ignore the crude because we want to look at the data that's adjusted for the educational level, and in this case, down here in the footnote, education, arterial stenosis, and physical activity. And we had one value that was significant, an odds ratio, for those people that had between 1 and 9 teeth. They were more likely to be high, 3 times more likely to have a significant disability reading on the disability score. So that's how that is read. And at 15 years, there were no values in the crude that were significant, and therefore adjusting was not even appropriate to be done. And similarly at 20 years. So we have one value out of many, many things that were looked at. And so at a point, p.05, when you do multiple analysis, some would say suggestive that's not that valuable because there's no correction for multiple analysis there. So as we start looking at research papers, learning a little bit about what these things mean becomes important. Excuse me. If we look at now what this is the survival data, the mortality data, and we look at this 21-year survival in 70-year-olds with and without teeth in chart A, that's at the top of your page. Those who are edentulous, if you just look at it grossly, versus those, the top line, who are dentate, I think you would agree that those who are dentalists have over that time period, lived fewer years than those who are dentate. And then if you look down here, the comparison of survival by log ranks. So they did this by the actual number of teeth, and you compare these graph lines to the key down here. You'll see that the people that have the least 0 teeth were the lowest in the graph, and the people that had the most teeth, they ended up about this point, which is somewhere between 12.5 and 15, they definitely showed a higher survival rate. And this is what the Danish investigators concluded, is that in the first table, tooth loss is independently associated with onset of disability and mortality in old age. Now, they drew that conclusion based upon one finding at that one period of time. And then their second conclusion is that tooth loss may be an earlier indicator of accelerated aging. So it would be helpful to see other people confirm this information, because it's not what I would consider strong outcomes, but it's interesting in outcomes that would need further follow-up with larger population groups. So here is another study, and this is a Korean study, and typically this is what these studies look like as the abstract. Here we have the association between tooth loss again, and in this case, periodontal disease and cognitive impairment. So what we're seeing a lot in the literature is not so much the epidemiologic studies, because the studies that we started off with are fairly old, but people are attempting to draw correlations between various aspects that, like tooth loss, like periodontal disease, and different aspects of characteristics that we see in high rates in the elderly population. So this one is cognitive impairment. And specifically, we're looking at tooth loss due to periodontal disease. So let's look at this one a little more closely. Well, we can begin here. There we go. I think the key gets stuck sometimes. Let's see if we can back up. Okay, so here's the slide. So the subjects are 438. They are in, when I say Korea, it's South Korea, of course, because we get very little information on North Korea. Now notice, all of these subjects are older than 50 years of age. Well, as a gerontologist, we don't consider 50 an elderly individual. That's a middle-aged individual. So they're combining two or multiple cohorts of people here. There's been no previous history of dementia or stroke. And the methods they use, they did do dental exams, so that's great. They used the mini-mental state exam score for cognitive impairment, and that's a well-recognized score as well. And they sampled people between a period of about almost 2 years. Okay. What they found is they had, of their sample, they had 315 women and 123 men. But look how young these individuals are. So we're not really seeing the older population groups here. What were their findings in this study? These are now adjusted findings. Remember, we had odds ratios before where we had crude data and adjusted data, and we focused on the adjusted data. So these are adjusted data that we're looking at. And the odds ratios are what they're saying is if a subject has lost 6 to 10 teeth, the odds ratio is 2.5 times that they will have cognitive impairment based upon their mini mental state exam. And if they've lost greater than 10 teeth, it's 2.7 times more likely to have a cognitive impairment based upon that score. And they used the 0 to 5 teeth loss as the comparison group. So those get a 1, which is the baseline, against which every other group is compared. Now, when they adjusted for age and education level, these specific aspects, hypertension, diabetes, hyperlipidemia, and smoking, what they found is that the odds ratio was 2 times, again, for a cognitive impairment based upon if you had lost 6 to 10 teeth, or 2.26 times if you lost greater than 10 teeth. So they concluded that you could correlate tooth loss with cognitive impairment among community-dwelling adults if they had no history of medical problems such as stroke or dementia, and these adults were aged 50 or greater. And so the question then arises, is this a coincidental finding that the same, if someone is becoming impaired, are they forgetting to go to the dentist, do their home care? And it's not, remember, it's not causative. They're not saying it's causative. They're saying it's a correlated finding. Let's move on to a different kind of study. Again, it's a tooth loss study, but this is related to nutritional status, which has, one could argue, has a more direct effect on whether or not you have teeth versus something like cognitive status. So this was a very large cohort. We like to see large numbers in these studies of over 3,000 people in Italy, northern Italy, again greater than or equal to 65. So we're definitely in the elderly range, and both genders. So one of their goals was to look at the prevalence of edentialism and see how it impacted the social and lifestyle factors of this population of older adults, and how tooth loss contributes to that. So 44% of the population was edentulous, and in both sexes. And of those who were edentulous, 17.5% wore no prosthesis. And people, 47.6% had problems in chewing, and nearly 14% had problems in swallowing, per report by the individual. So this is self-reported information. And to continue, this is the same study now, women independently had associated risk factors. And for example, if it had been greater than 23 years since their menopause, if they had greater than 3 children, and if they were living alone, you can see that their odds ratios are all greater than 1 for having nutritional issues associated with tooth loss. For men, however, the factors were different. The factors had to do with a serum albumin of less than 40 grams per liter, current smoking, and former smoking. And you can see that those individuals who were current smokers were 4 times more likely to have tooth loss and nutritional issues than the baseline group. And this is what the data looks like as it's presented in the paper. I wanted to show you this so that you know how to navigate these kinds of data sets. So the title is The Results of Logistic Regression Analysis with Stepwise Forward Selection of Variables Significantly Associated with Edentialism. So let's look at this particular, here's the odds ratio, OR. And what they're saying here is that you want to look for the largest odds ratio. Now, in this particular, it's not always true of all data sets, but you can look closely at these numbers, and we're looking for anything that's significant at a 0.05 or a more significant value, and certainly 0.0001 is much more significant than 0.05. Here's a non-significant value. Here's a non-significant value. Sometimes people put into their reporting the actual numbers, and so you need to know what's significant and what's not significant. So anything less than 0.05 is significant, but when you do multiple analysis, it's better to see even smaller p-values. So here we have the significant. In min, we're looking now at min. These are the independent factors. We are going to look at what we just saw noted on the previous slide. I just want you to see where I got that. So here's min, who are associate odds ratio of 4 times greater likelihood to be edentulous the higher the age group, in this case greater than or equal to 85. Here is the current smokers, 4 times greater likelihood to be edentulous if you're current. But even if you're a former smoker, again, highly significant at nearly 3.5 times more likely to be edentulous. And for women, the values are quite a bit, the odds ratios are quite a bit less, but again, they are significant at very high levels. Living alone is here. We didn't mention previously the odds ratio for being greater than or equal to 85. That's significant. Years since menopause and number of children being the standard value, and number of children greater than 3 having a higher odds ratio. So that's what the data looks like as is presented in the paper. Here's another result from the paper. And these can look very daunting and very busy, and that's why I thought it was important to actually show you the data that's presented there, because learning how to interpret literature is something that's extremely valuable for us to be comfortable with. So what this is the we had the independent variables on the previous slide, and these are the dependent variables, and the dependent variables over here in the first column are chewing and swallowing. And you know, the independent variables, if you reflect back, they were gender, for example, is one example. So let's look at the odds ratio here. Again, look at our p-values, highly significant. This is the only one that's p.05, which is still significant, but because we're doing so many analysis, it's not as strong as this 0.0001. So let's just pick out the type of dentition, specifically edentulous, is critically important. And down here in the bottom, you can have the key that demonstrates what these different headings mean, because each one of them is significant at a different level. And this is associated with chewing and swallowing. So what it says is that in chewing, if you are edentulous, you're going to have probably nearly 7.5 times greater difficulty with chewing when you're edentulous than compared to people with their natural teeth. Well, I think we kind of know that, but it's nice to see that this is scientifically proven. TD represents subjects with 0 to 19 teeth, whether they have some kind of partials or not. And you see the value there is nearly 4 times more difficulty in chewing. So it would be what we would expect. The more natural teeth, or the fewer natural teeth, the more difficulty. So let's jump down now here to swallowing. And again, the highest value of difficulty swallowing is with edentulous at over 2.5 times greater. And definitely difficulty in chewing and difficulty. If you have difficulty in chewing, it is going to be more difficult for you to swallow. Those are the findings there in this particular study. Well, let's go on to tooth wear and tooth surface loss. And tooth wear is the pathologic loss of tooth tissue by process other than caries. And we could assign 4 categories to these: abrasion, attrition, erosion, and abstraction. Attrition, as you remember, is the loss of enamel or dentin or even a restoration by tooth-to-tooth contact. So it's typically very, very flat. And you notice I didn't quote any literature. There's very little to none literature on attrition in the elderly. There is some literature on erosion, but not really more descriptive. So, for example, what it is, it's a loss of hard tissue as a result of chemical action and not through bacterial involvement. And it's divided into 2 types, both intrinsic, that typically is associated with eating disorders, although it can also, and more likely in the elderly, we see it associated with GERD, which is gastric esophageal reflux disease, so acid reflux. And it can be extrinsic. And we do see this in the elderly as well, with fruit juices, particularly citrus drinks or citrus lemons, sucking on lemons, or acids in soft drinks can bring this about. Abrasion is the loss of tooth substance from factors other than tooth contact. We typically think of toothbrush abrasion. However, there are other kinds of abrasion as well that frequently are a result of habits holding things in the mouth as part of an occupation. Again, little data has been collected on an epidemiologic basis. I did want to mention abfraction because this is defined as non-carious cervical lesions, or you can trade out the cervical lesions for cervical wear or cervical erosion abrasion. Depends on who you read as to how it's defined. This is really a theoretical process that relates to occlusal forces and the stresses they create theoretically in the cervical enamel and dentin, and it brings in erosion and abrasion and a whole variety of, even at times, attrition. And this was a relatively recent term in the last half of the last century, but really it exists in the laboratory, and it really has not been demonstrated that it is a separate entity in vivo. And so it's a theoretical, it's hypothetical, and so I prefer not to use it because it is no different. It's just a combination of some of the other 3 activities that contribute to tooth wear that have been discussed. And these have really been proven as an significantly different in finding in human beings. So what about the functional effects of all of these, because that's really what we want to talk about, is how are the functional effects of tooth and tooth loss impacted in the elderly. So I wanted just to remind you of the word function and its synonyms, because don't we want to know how effective the use of teeth can be? And there have been some studies. There was a recent review of the literature that was published in Gerodontology in 2012 that looks at dental status versus masticatory ability, which of course is a functional capability. These studies were much more prominent 30 to 40 years ago. You see, they relate to how well people can chew, and the way they measured this was they looked at, they would have people chew various food types and then have them spit it out and run it through a sieve and grate it. And so they're not doing those studies too much anymore, but this was a nice summary of the data that was accumulated. And again, this particular picture looks at, excuse me, looks at just part of the slides, so there's much more data than this of summarizing what has gone forward in the literature. And so as a precursor to that, let's look at things like if you can't masticate your food, which is the function of teeth, right? Then how does that impact your life? Because fewer and fewer of the direct masticatory or functional studies are being done in and of themselves. They're attempting to draw these correlations, just like we saw previously. So here's an abstract looking at these edentulous status and how that relates to weight loss. Let's just look now at the background. So they're hoping to establish a relationship between poor oral health and subsequent weight loss. They only covered a 1-year period where they looked at weight, and they used community dwelling older adults. There were 563 of them. This is again data from that New England study, or a New England study. It is related to the same data pool, but different author and different papers. These were people 70 years and older, remember. So I've already familiarized yourself with the methodology of the study. So they started off doing the exam by the dentist, and then 1 year later they called the participants and asked them about their health and their dietary practices and how much they currently weighed. And what they said was, these are their results as a result of getting that data, that approximately 1/3 of the sample had lost 4% of their previous total body weight, and 6% of the men, and 11% of the women had lost 10% over that last year. So when they concluded that if they controlled for all of these things like gender and income, advanced age, and their baseline weight, that edentulousness was an independent risk factor for significant weight. Their odds ratio was 1.6, so for 4% weight loss, and 2 times greater risk if you were edentulous for a 10% weight loss over a 1-year period of time. So they concluded that edentate status is an important risk factor for clinical significant weight loss among these individuals. And really this is consistent with the previous study showing that if you were edentulous, you're going to have harder problems chewing. And typically people that have harder problems chewing probably don't intake as much, or and as a result perhaps don't get enough calorie load. So this is what their multiple logistic regression analysis looks like. And you can see that they said that if you were Female, it was a point, hopefully this means a 0.05 and not less than 0.5, because if it's 0.5, it wouldn't be significant at all. So, and yes, I'm looking at the confidence interval, and this has a significance to it. So I think this is a misprint here that I hadn't noticed before. They've indicated which of these are significant, and you can see those values, but edentulous is significant, as is dependence in one or more activities of daily life. This one is not. Baseline weight is but barely. Annual income is not. And it looks to me like this one is not, just in looking at the confidence intervals, although they've marked it as. So again, you have to look at these things very carefully. Just because the authors interpret it a certain way, you want to take a look at the data itself. So let's see if we can move on to the next slide here. Eventually, I think it will move. There we go. So your question might be, we've done a lot of discussion about tooth loss, is, well, how many teeth do people need? Well, according to the World Health Organization, 20 teeth, 20 natural teeth are needed, and that should be the goal of all of us throughout the world, is to help foster the retention throughout the entire lifespan of this functional, aesthetic, and natural dentition of not less than 20 teeth, and that's not counting any kind of prosthesis. Now, you and I know that people can function without any teeth. We know that. But how well do they function, and does that functional level decline with tooth loss? And I think we can all agree that yes. We've looked at a number of studies that show that yes, it does. Some of the outcomes can be malnutrition, compromised physical health, even psychological health. People like to look good. They notice when they don't have their teeth that impacts them and their self-esteem, their oral health, quality of life. These are some of the factors of some of the studies that we've done, and I only mention it here because we'll have a lecture on oral health, quality of life, and how oral health does impact a variety of psychological issues. So I just want to suggest that to you so that you can consider that, and we'll discuss that later. And the last, I think this is the last graph I want to show you, is this is just over time in the United States. These are the National Health and Nutrition Examination Surveys from 1988 to 94 is the darker blue one, and the more the 1999 to 2002. And you might say, well, why are we looking at that data that's so old? They don't always publish the NHANES data, and they don't always ask the questions that we want to look at every time they go out. But I think what you can see is that the mean number of permanent teeth is increasing in each one of these for over the various age groups. And that's what we hope to encourage. And we're not to 20 teeth yet, but hopefully if we had newer data, we would be edging even closer. So that's our goal. And so that's just a brief overview of some of the epidemiology of oral health issues. You can see that there's a lot of holes in this data. Some of it has not been done at all. Some of it hasn't necessarily been as thoroughly done as we would like to see with big enough populations to really give us a clear picture. But we're going to work with what we have, and this is our overview. So thanks for your attention, and I look forward to talking to you again.